Okay, we still do have a couple of people joining in, but in the interest of time, we're going to go ahead and get started. Good afternoon and welcome to today's webinar, Finding Lost Revenue in a Cash Flow Crisis. This is the last of 3 sessions that have been hosted today by the chapters that make up the HFMA Region 5, Alabama, Florida, Georgia, South Carolina, and Tennessee. As a group, we come together once per quarter to host a webinar day, and it gives our members the benefit of attending sessions from other chapters. And if you check out the events section of your chapter's website, you'll see that all of us publish activities from the other groups. And I encourage you to take advantage of the education sessions offered, not only at your chapter level, but also from the other chapters in the region as well. I'm Laurie Hebe. I'm a Georgia HFMA Education Committee volunteer. A couple of housekeeping items before we get started. All of the phone lines are on mute to avoid interruptions during the broadcast. I ask that you please submit your questions via the question box at any time, and I'll coordinate with our presenters for their answers at the end of the session. So again, if you see something or hear some comments about something in particular, go ahead and record that question as you think of it, and then we'll take care of all of them at the end. Today's presentation and the recording, they're going to be made available directly from the presenters. When I send you the continuing education credit form on Friday, I'll include information about accessing the materials directly from the Cloudmed website. And everyone on today's call is eligible to receive those continuing education credits for participating. This session is being hosted by the Georgia chapter of HFMA, and as part of our process to extend credit, please be on the lookout for that form in your email, as I mentioned, and you'll be able to use that form to self-submit for your credit on the HFMA website under the membership info tab. Finally, I'd like to take a second to recognize and thank our chapter sponsors. Okay, if you'll see their logos on the screen here. We appreciate your support, not only for today, but throughout the year. Now I'll introduce the speakers for today's session. Erica Gordon is Director of Medicare Revenue Services at Cloudmed. Erica specializes in Medicare hospital reimbursement and regulations, and she oversees Cloudmed's Medicare audits, research, and recovery efforts. She is certified inpatient and outpatient coder and is one of the company's experts on ICD-10 and general billing and coding guidelines. Katie O'Connor is Director of Client Success at Cloudmed. Katie has extensive experience overseeing underpayment review projects for large hospital systems in Illinois, Florida, and Pennsylvania. She helps make sure clients are getting the maximum value partnering with Cloudmed. So Katie and Erica, I'll turn it over to you. We're ready to begin.
All right, thanks, Lori. I'm going to go ahead and get us started here. Hi, everyone. My name is Katie, and I am very glad that you are here with us today. I know that Erica and I are both very excited to be joining you on this virtual platform on behalf of Cloudmed. Thank you to HFMA Region 5 for allowing us to present on today's webinar day. And also thank you to Lawrence Harris, who is one of our fearless leaders here at Cloudmed, for setting us up with the wonderful Lori, who has been working with us behind the scenes. Our goal with this presentation today is to provide some tangible takeaways from a few case studies which highlight some specific causes of lost revenue that we at Cloudmed consistently find amongst our clients across the country. Like Lori mentioned at the start, this webinar is not going to be published, but if you are a provider with us on the line today and you would like a copy, feel free to reach out to either Erica or myself, and we will be happy to send you a copy of the finished presentation. All right, so in the interest of time, we will dive right in to the agenda. So Erica is going to start us off, but we're going to talk through the effects of COVID-19 on hospital reimbursement, and then we'll go through those 7 tangible case studies of ways to recover lost revenue. The first being new tech add-on payments, and the second case study being new COVID-19 add-on reimbursement. Then we will do a deep dive into some Medicare Advantage contract analysis, followed by a fun, never-ending new drug billing quantity case study. we'll go into the complexities of Medicare Part A to B rebilling, and then round out with some incorrect drug denials that we frequently encounter here at Cloudmed, as well as some tips on how to deal with some more difficult payers in the market like TRICARE and federal workers' comp. So before I dive in, I did want to get everyone up to speed on Cloudmed, as we are probably a new name that not too many people are familiar with yet. So back in October, Triage Consulting Group merged 26 years of zero balance experience in revenue cycle with Revant's robust tech platform to form Cloudmed. Cloudmed is a revenue intelligence solution for hospitals, combining human expertise with advanced technology and machine learning for a more thorough, predictive way to realize lost revenue. Erica and I are both very excited to be on the new Cloudmed team. And without drowning on about this for too much longer, we will plan to give away some of our secrets today to finding lost revenue during a time when we know hospitals need it. So the next slide, recovering lost revenue. So that's what we're all about at Cloudmed. So you don't need me to tell you that the existing challenges and hurdles that providers face have now been amplified by the pandemic. COVID-19 has caused our American hospital systems to lose an average of $50.7 billion per month. And that number is just from 2020. So I really don't want to think about that number continuing to grow in 2021. As we all know, there have been immense number of layoffs and furloughs. Hospitals had to limit elective procedures, and doctors, nurses, medical staff, everyone is still working around the clock to keep their community safe. And on behalf of everyone here at Cloudmed, I do want to say thank you. If there's anyone on the line, I know that we are all so grateful for those first responders and those frontline healthcare workers to keep us safe in this pandemic. But now more than ever, we really do understand the need for providers to capture all possible revenue, which is our purpose here today. So our goal, like I mentioned, is just to share some tangible takeaways of revenue leakage that your health system might be experiencing unknowingly. We've noticed that even when providers get things right 99% of the time, that remaining 1% can still translate to millions of unexpected dollars slipping through the cracks, especially when there is a systemic error that comes to the surface. So diving right in here, I'm going to pass the mic over to Erica Gordon, who runs our Medicare review team. She is super smart, and just like me, she is super passionate about recovering lost revenue. So Erica, I will let you take it away.
Excellent. Thank you so much, Katie. So I'm going to start by walking you guys through several Medicare specific case studies. Medicare is very passionate about their reimbursement methodology. Want to show you guys a few unusual scenarios. The first case study that I want to kick off with is a kind of an interesting product that qualifies for this CMS New Tech add-on payment. And I want to give you some quick background on the New Tech add-on payment in general. It was created to help give providers a boost on their IPPS payments when they're utilizing those new technologies, new medical services as they're FDA approved. So manufacturers, they have to apply for their specific product to earn an add-on payment. And there's 3 different criteria for a manufacturer to be eligible for this payment. The technology has to be new, hence the name. It has to be expensive. So it has to be costly enough that your regular DRG payment is going to be inadequate to cover the costs. And the technology has to be better. So it has to show some substantial clinical improvement over what's already out there available on the market for hospitals to use. So the individual add-on for a service, it only lasts for a few years. So if your facility is on the cutting edge, you're certainly going to want to make sure you're capturing these dollars when you can while that add-on is still available. So CMS every year, they do an analysis of what technologies they feel qualify for that new tech add-on, and they release it in the final rule every year. So for fiscal year 2021, which started 10/1, Medicare is estimating a big jump in their spend on new technology. It's going to be 120% increase over fiscal year 2020, and they're estimating $874 million in spend. So in that final rule, CMS, they release the coding requirements, and the way the coding requirements are structured to get payment for the new tech add-on program, most of them are PCS codes. So if a new technology PCS code is assigned, that will trigger reimbursement for the new tech add-on. Now, occasionally there are some diagnosis coding requirements, or there are some NDC code requirements, but those are also detailed in the final rule. And we certainly know that these changes can be pretty tough to keep up with every year. There are small changes. And so Cloudmed does have an IPPS memo where we summarize the coding requirements for new tech add-on, in addition to some of the updates that come out every year. So we're happy to provide a copy of that memo to any providers on the call. Katie mentioned our contact info is up at the end. Feel free to ping us for a copy of that memo. So heading back to the slide, the most common cause of NTAP lost revenue, we're looking at the teal box on the left side. It's a missing or miscoded procedure code. That's going to be the most common reason that you don't get that add-on payment. And so there's a very small section of the manual, of that PCS manual, that describes all the codes. It's only about 5 pages out of 564 that are dedicated to the new technology codes. But since these services really aren't utilized that often in, when they're first adopted, that your coders might not be as familiar with this section of the manual. So the NTAP example that I wanted to cover for this particular case study is the drug Zenleta. It's a new antibiotic, and it's used to treat patients that have community-acquired bacterial pneumonia. And the way the drug is provided, it's usually done as an IV infusion over anywhere from 5 to 7 days. But what's interesting about this particular drug and this particular product is that there's actually an option in the prescribing information to finish out that course of treatment with an oral antibiotic. So the reason that I want to highlight this service and explain why it's so unusual is because typically Medicare considers their self-administered drugs to be statutorily non-covered. So for this drug, not only is the self-administered drug covered, it actually receives an additional add-on payment in addition to your DRG of over $1,200. I'm going to point you to the bottom of the slide here with that teal bar, which is showing you the dollar impact. The max add-on payment for this drug is $1,275. So when you have this drug Zenleta administered in the hospital, even if it is the oral tablet part of the administration, you should make sure you're reporting one of those 3 PCS codes that I have on the slide that start with an X, that indicates that they're a new technology procedure code. And failing to add those PCS codes to your claim, even though they may not impact your DRG reimbursement, that could be a very real cause of lost revenue for your organization. And another reason, a more general reason why it's important to make sure you're getting that add-on payment, why you're assigning those appropriate PCS codes, is because even when you get the add-on payment, CMS isn't covering 100% of the cost of this product. It's actually, it used to be 50% of the cost. And as of fiscal year 2020, they increased it to 60 to 70% of the cost is getting paid back on through that add-on. So that's why it's really critical to have a quality assurance process in place to vet the billing and payment of these new technologies. And we've seen a good number of our clients, they'll do this as a function of the revenue integrity teams, or sometimes it's assigned to the government reimbursement divisions of PFS because it's very specific to your Medicare and your Medicare Advantage plans. All right, so that wraps up this first slide. Also, for anyone who came in a little bit late, if there are any questions, feel free to add them to that chat box. And then at the very end of the presentation, Lori will pass them along to us for review. All right, so heading over to our next area of potential opportunity. And this one is interesting because it is a brand new program that CMS just started in November. So another great reason to have your coders brush up on these new technology codes that are in the manual. It's that as of November 2nd, CMS is allowing these new COVID treatment add-on payments. And similar to the NTAP program, CMS's goal is to try as best they can to ease some of that provider financial burden. They're aware that the cost of these new technologies is not baked into the averages for your DRG weights. So they want to try and increase your IPPS payments to mitigate any of the potential financial disincentives for providing those new treatments during this public health emergency. So there is eligibility criteria for getting an add-on payment for using those COVID new technologies. And the criteria here is also threefold. So it has to use a drug or biological that's authorized to treat COVID-19. So it could be authorized under the FDA emergency use authorization, or it could be just officially FDA approved for treatment of COVID-19. So then the second criteria is that the inpatient encounter does have to be a COVID case, and it does have to have a positive test documented in the medical record. So if you're administering remdesivir for another indication, you wouldn't get the add-on payment if it's not a COVID case. And then the last criteria is a dollar criteria. The operating cost of the case has to exceed the operating federal payment under IPPS. So there are currently only 3 drugs or combination of drugs that qualify. So I have them listed on the slide here in the order of the FDA approval or the FDA EUA date. So the first one that I want to highlight here is remdesivir. So that one came, the effective date for the NCTAP payment for that is 11/2 of 2020. And I've added the PCS codes for that on the slide in the first column. And then the second drug that qualifies is your COVID-19 convalescent plasma. And that is in the second column. They're also effective 11/2 of 20. Now, where this payment amount gets a little bit tricky is when we introduce the third drug combination that qualifies for the new COVID add-on payment. And that's for the combination of remdesivir and baricitinib. So that one, that payment add-on is effective a little bit later. This one didn't go into effect until November 19th of 2020. So what's important to notice here is that there are 2 different coding requirements if it was provided in 2020 or if it was provided in 2021. So those 2 differences are listed on the slide. So make sure when you head back to your shop to do a sweep for these cases, just acknowledge and notice that there's going to be some coding differences for your retro look back in 2020. So you may notice that there's one big COVID treatment with an emergency use authorization that is not listed on the slide. And that is your monoclonal antibody treatments. So there's 2 monoclonal antibody treatments that do have an EUA from the FDA, but they are not authorized for patients that are hospitalized due to COVID-19 or that require oxygen therapy due to COVID-19. So you won't be getting the add-on payment for that on the inpatient side, but the drugs are payable if they're administered as outpatient. So for each of these case studies, we like to, follow the revenue. Let's look and see what the dollar amount is for each of these areas of opportunity. So for the new COVID add-on payment, it's different from the new tech add-on where they don't have a very specific dollar amount for each drug that they've assigned as a maximum value. Instead, it's going to depend on your DRG weights, the cost of the case. And so they're calculating that max payment. At the very bottom of the slide, you can see the 2 options. It's going to be lesser of 65% of the operating outlier threshold, or it's going to be 65% of the amount by which the cost of the case exceed that standard DRG payment. So I promise I won't bore you with all of the math today, but in the 4th interim final rule where they released the new COVID add-on payment approval, they were doing some simplified examples and estimating dollar amounts, and CMS calculated a pretty good range of add-on payments. The examples they gave were anywhere from $6,500 up to $19,500. So there could be some really significant payments for your facility if you make sure that these cases are coded appropriately. So we certainly encourage your coding department to monitor for correct assignment of these codes to make sure you're getting that revenue boost on your COVID cases when those new drugs are administered. All right, so the next slide that I want to tackle, thank you, Katie. I'm going to continue discussing some reimbursement changes due to COVID-19, but this is more relating to your Medicare Advantage plans. So everyone's very familiar at this point in the CARES Act that Medicare introduced that 20% DRG weight increase for your COVID cases. But there's a little bit more ambiguity in how perhaps your Medicare Advantage payers would, whether or not they would allow that 20% boost as well. So I want to highlight here on the very first column, we're looking to see whether or not the payers apply that 20% DRG weight increase. Two very big payers, your United Healthcare Medicare and your Cigna Medicare, they've already publicly stated on their websites that they are moving forward with the 20% DRG weight increase. And that is for your COVID-19 cases. So this applies for your contracted providers who, if the contract is based on IPPS reimbursement methodology. So moving down the list on that table, so we've got a good green check mark next to your UHC Medicare and Cigna Medicare. They should be paying that 20%. Also your non-contract Med Advantage. Those payers in general should be, they're required to pay at least the Medicare rate. So we would expect the 20% add-on from any of your non-contract Med Advantage. But I will say let's move down to the very last row. Your contracted Med Advantage is a little bit of a question mark for that 20% boost because Cloudmed has identified a good number of Medicare Advantage players that aren't automatically applying that 20% DRG weight increase. So we know that CMS doesn't intervene in any of those managed care contract agreements, but there are nationally, a good number of Medicare Advantage payers who contractually follow those CMS guidelines. They contractually follow IPPS reimbursement methodology. So in order to help you identify if there's any underpayment opportunities for your contracted Med Advantage, my recommendation is to evaluate your specific contract language and evaluate the rate section and take a look and see if there's any favorable verbiage for going ahead and incorporating CMS changes to payment methodology into the payment. And so if your contract doesn't explicitly address just adding those CMS updates, there is also some precedent from CMS that you can fall back on. So what I recommend doing here is do some research, see how your managed Medicare payers have previously responded to CMS changes. So did they take that 2% sequester reduction without a contract amendment? Did they reduce payment for 340B acquired drugs with the modifier JG without a contract amendment? So if they had previously done one or both of those changes without requiring a contract amendment, then you'd have a very strong case that that payer should go ahead and apply the 20% COVID DRG weight increase during the public health emergency as well. So if after doing your research, you find that your Med Advantage payers did previously apply the CMS updates that resulted in a reduction, but didn't apply the CMS updates when they resulted in an increase, we certainly recommend reaching out to your payer counterparts and confirming your understanding of how these claims should be paid and getting that information in writing so that you're both on the same page about whether or not the 20% DRG add-on should apply during the public health emergency. And before closing out this slide, I also want to highlight that CMS has extended the suspended sequestration through the end of Q1, 3/31/21, and that no longer applying the 2%, that's effective for all inpatient, all outpatient claims. It's not just for your COVID cases, it's for any Medicare claims. So we want to make sure that your modeling software is updated to remove that 2% reduction for Medicare. And then again, take a look at your Medicare Advantage payers and see if they're following suit, assuming that contract language is supportive. And as you can see in the last column of that table on the slide, UHC and Cigna have also publicly stated that they are going to remove that 2% reduction. your non-contract Med Advantage should follow suit. And then you can follow that same process that I outlined for your contracted Med Advantage to determine if they should be removing that 2% reduction. All right, so Katie, thank you so much. All right, so moving on to the next case study. We just spent some time talking about some inpatient potential areas for opportunity, namely related to Medicare. So now I want to shift over to another potential opportunity for you to capture some revenue on outpatient risk. So this slide is aptly titled The Never-Ending Cycle of New Drugs, because this cycle is genuinely never ending in the revenue cycle world. And we have new drugs that are being approved by the FDA every month, every year. And for those really high dollar IV drugs, we can see a few dozen approved in a given year. But we really can't predict when exactly that FDA approval is going to be finalized. And Medicare, it's a good thing for Medicare that whenever a new drug is approved and is considered reasonable and necessary, Medicare will immediately reimburse for it. But unfortunately for providers, the FDA approval dates are not really synced up with the CMS quarterly updates where they release the new HCPCS codes. So you'll have an approval date, but you don't have a specific C or J code that's for that particular drug yet. So the way that CMS decided to handle this and help providers bridge that gap to make sure you're getting reimbursed for those new drugs is this catch-all HCPCS code C9399. That's on the far left-hand side of the slide on the timeline. So that code can be used from the date of FDA approval until the drug-specific code is released. So I want to start by walking you through this timeline. We're going to talk through the specific drug Capzory through the life cycle of this drug and how CMS went through and created the different HCPCS codes for it. So Capzory, or levolucovorin, it can be used for patients that have metastatic colorectal cancer. And it was approved for this indication on October 19th of 2018. So at that point, from that date, providers could use that unclassified HCPCS code C9399. But C9399, it's a little fickle when you put it on the bill. It can only ever be billed with one unit. And if you've ever tried submitting it with more than one unit, you will get a lot of RTPs. So you want to make sure that your CDM is set up for C9399, one unit. And then the amount administered to the patient is actually communicated to Medicare through the NDC code and through some remarks. So for that 175 milligram vial, like I mentioned, you set up your CDM for C9399, one unit. So heading to the middle of the timeline here, April 1st of 2019, CMS released a temporary code that was specific just for Capzory, and that code is C9043. So this code is reported per milligram. So at this point, certainly you want to add the new code to your CDM for that same charge line, replace the C9399 with the new temporary code. But the common error that we find here is that the temporary code is updated, but the units might not be updated from 1 to 175 for that 175 milligram vial. So if that happens, instead of getting paid 4 milligrams per vial, if you look at the example dollar impact on the very bottom of the slide in teal, you're looking at getting a $3,600 loss per claim, because instead of getting paid $4 per milligram, you're getting paid $4 per vial. So this is certainly a big revenue loss, especially considering that your infusion patients are often coming in for recurring visits. They have chemo cycles that continue on for quite some time. So that can be a really big loss that you're not aware of. So then the third stage here for this drug, talking through the next stage of updating the HCPCS coding here, CMS released on 10/1 of 19, far right of the timeline, the permanent HCPCS code J0642. So, again, you're going to do that CDM update the HCPCS codes. But what CMS did here, which is a bit frustrating in my opinion, they updated the billing units from 1 milligram on the temporary code to 0.5 milligram on the permanent HCPCS code. So that means that for that same 175 milligram vial, whereas previously you would have billed 175 units, now you have to bill 350 units. So that is another challenge that, that providers need to be aware of for their CDM maintenance. And then if you think through those few dozen intravenous drugs that are being approved every year, and they're all going through HCPCS code changes at different times during the quarters, that certainly adds a huge layer of complexity to your CDM maintenance. And then we recognize that process of keeping up with the new drugs, keeping up with the dosages and the associated units, at times it can be pretty manual. So certainly we recommend touching base with your pharmacy department and making sure that this is front of mind. What is the process for adding new drugs for your CDM? What is the process for changing out the HCPCS codes when CMS makes updates? You know, we don't find underpayment risk for every drug, but we are guaranteed to find issues with at least a few drugs when we perform this type of review. So I will say, in terms of how other providers are handling it, some healthcare systems we work with, they'll handle new drugs billing like a special project. And if your facility isn't already doing so, it can also be a good case for your analytics team to go and do a 1-year look back and confirm that those new drugs are captured and billed appropriately. So we also encourage providers to look into billing requirements for new drugs on your commercial volume. We do tend to find opportunity across some commercial payments or commercial agreements that might carve out your drugs by HCPCS code. All right, so that is the last of my Medicare case studies for this afternoon. I'm now going to pass it over to Katie, and she's got a few more interesting topics to cover, some more revenue for you guys to find. So thank you, and I'm going to pass it over to Katie.
All right, thanks, Erica. So this next case study that we're going to go through is going to be short and sweet. We are going to shift into Medicare Part A to B rebilling. So you guys might be, I'm sure you are aware that since 2013, CMS has allowed providers to self-audit under the A to B rebill process, which allows for hospitals to be paid at outpatient rates on a bill type 121, otherwise known as a super bill, when a patient is admitted as an inpatient, but they ultimately don't end up meeting that 2-midnight criteria. To give your staff a refresher, anyone who needs a refresher, honestly, on this self-audit process, we really recommend referencing MLN Matters MM8445, which we put on the slide today. This gives a really thorough, a really nice summary of the complex billing requirements for self-auditing and for A to B rebilling. So, okay, this has been in effect since 2013. Why are we bringing this up today? It's because we have noticed that if there are emergency room or observation room charges incurred on the front end of these short stays, sometimes some of the providers that we work with don't end up putting those charges on an outpatient bill type 131 where they could be getting additional reimbursement. So for example, on this particular case study, we focused on CPT 99285 for a level 5 emergency room service. That on average typically pays around $500. So although that number doesn't seem overwhelming, doesn't seem huge, if it's consistently missed, then these unreimbursed emergency room charges can add up to tens of thousands of dollars over time. So at Cloudmed, we recommend sweeping your self-audited volume for any emergency room charges found in Revenue Code 450, and also looking for those observation room charges in Revenue Code 762 that might have not made it onto a 131 outpatient bill type for correct and separate Medicare payment of those pre-admission services. So we bring this up today because even if you have a really sound self-audit process on the Medicare side, don't forget about checking checking your managed Medicare payer contracts and policies as well. I feel like that's another thing we really are trying to drive home through this webinar, is encouraging you to check your managed Medicare contracts to see if they pay according to CMS guidelines. So as it relates to this specific example, Humana Medicare has their own A to B rebill policy and it mirrors CMS's. So it's important to sweep all of your managed volume for potential missing dollars in this risk area, just making sure that you are getting those charges incurred on the front end, those emergency room charges, those observation charges, getting those on a Medicare bill type 131 so that you are getting reimbursed correctly. All right, so we only have a few more case studies here. We are going to move away from Medicare risk areas and go into some commercial risk areas. We did want to focus on another case study that hones in on that post-payment area of the revenue cycle, this time as it relates to incorrect drug denials, specifically for the drug Sandostatin for commercial payers. So just to get everyone up to speed on this drug that we're going to talk through, Sandostatin regulates the functions of several endocrine and exocrine glands. It can stop the growth of tumors in the body. So not only are patients required to get authorization for Sandostatin, but as the same as it is for many other high-cost pharmaceuticals, insurance payers typically have their own clinical policy bulletins that the provider has to follow in order to receive coverage and reimbursement for the drug. So these policies are updated frequently, and while we certainly appreciate the insurance payers adding new covered diags as they are supported by the FDA labeling or drug compendia or peer-reviewed studies, but we have seen cases where there is a delay in the claims processing system being updated with these published covered diagnosis codes. So the goal of this case study is to encourage providers that are with us on the call to really scrutinize those drug denials and compare them to the clinical policy bulletins as kind of a first step. So Cloudmed has identified a bulk amount of incorrect payer denials surrounding this drug, Sandostatin, which stems from payers citing their own policy bulletins as reasoning for non-coverage, when in reality, you check the claim, there actually is a diagnosis code billed that falls within that policy's list of qualifying codes for coverage. So before accepting an experimental denial, or even before you even think about drafting up an appeal, we recommend searching that payer's policy bulletin online for the listing of covered diagnosis codes and compare that with what's already on the patient's current claim. Sometimes we find that a covered diagnosis code is on the claim already and the payer just missed it. And this happens more often than you would think. These are very easy to overturn, whether you call the payer and reprocess it over the phone or you send a submission on their electronic portal. And in this case, in this particular instance, the underpayment, the root issue stems not from the claim missing any information, but from the payer not following their own written policy on the drug. And I did want to, so that's one portion of some invalid drug denials, one way that it can go. And sometimes the reverse is true and the claim actually is missing information. So I did want to dive into that scenario as well, in case this is something your facility runs into on a regular basis. So another common drug denial that we come across as it relates to diagnosis coding is for series accounts. So let's say that a patient is returning for infusions to your facility over a specified period of time. A physician might write the order for several months at a time. So for example, maybe 300 milligrams every 2 weeks for 6 months. That's a lot of visits, right? So let's say that the order with the diagnosis code, it might not be scanned into the chart for each of those individual encounters. So if there is a qualifying diagnosis code reported on one of the encounters in a series visit and the drug charges are denied, but you're noticing that other claims are being paid for the patient, then Cloudmed recommends reviewing the records for the recurring infusion as a whole to ensure that the encounter documents the medically necessary indication for the service. So this recommendation is supported by the ICD-10 CM guidelines for coding and reporting. Those guidelines state that chronic diseases treated on an ongoing basis may be coded and reported as many times as the patient receives treatment and care for that condition. So if a qualifying diagnosis code is able to be assigned for each visit, then the denial can likely be overturned with a corrected claim. This is just another research step to ensure that you are receiving appropriate coverage and reimbursement for the medically necessary services that your facility is delivering. So back to the slide, tying this back to a dollar amount. For this specific example, you may see commercial reimbursement for this high cost drug at about $10,000 per claim. That does vary, obviously, based on the payer, but that is our estimation here. And we sometimes notice that payers target a certain type of drug across volume over a specific time frame. So if you find an invalid drug denial on maybe just 1 or 2 cases, you're going to want to be sure to sweep and query across all of the volume for that patient with that drug administration within a similar window of time to make sure you're not leaving $10,000 on the table each time the patient is coming in to receive these types of high cost drugs. Okay, so we are going to move on from high cost drugs, going into one of the last things we're going to touch on today is some difficult payers. So we are going to switch gears, get you guys some new information that our teams have gathered regarding government payers, making sure that you are receiving the appropriate reimbursement from kind of unique payers like TRICARE and federal workers' comp. So again, we are focusing on the post-payment portion of the revenue cycle as it relates to this case study covering TRICARE third-party liability. We find consistent opportunity in non-compliance denials, which you guys as providers, your vendors, your partners, you are used to pursuing these with the patient. But in this situation, we are going to suggest moving the patient balance back to the payer once the patient has become unresponsive, which, as we all know, is more common than we would like it to be. So in the case of TRICARE's third-party liability denials, or as I'm going to refer to them just as TPL denials for the rest of this presentation, if there is a diagnosis code bill that falls within these included diagnosis codes listed on the slide in that first row of our table, if there is a diagnosis code bill that falls within that range, then a TPL denial is triggered. And this indicates that TRICARE believes that another party might be liable for the accident or for the injury that is causing their member's hospital visit. And just as a reminder, I should mention that this type of denial that we're talking about only occurs with claims that have $500 or more in charges. So coming back to the slide here, TRICARE they also provide a subset of excluded codes that you can see within the certain range in the bottom row. And these codes should not trigger a TPL denial. They contain more irrelevant conditions that are not indicative of potential third-party liability, like bug bites. So if you are wondering why I put a picture of a bug on this slide, I can't make this stuff up. Those are the diagnosis codes for bug bites that are excluded from the TPL denials. So you're really going to want to watch out for these denials on the excluded list because they should absolutely be considered invalid. So what TRICARE is requesting when this type of denial is issued is for the patient to complete a TPL form, also known as a statement of personal injury. And this basically confirms that no third party was involved. But the TRICARE manual actually allows for some exceptions. The manual states that if TRICARE can determine that there is little or no TPL recovery potential, so for example, if someone falls over in their own home, then the form does not need to be completed. And the manual additionally states that if the provider can demonstrate through the medical records that there was no third-party liability and the beneficiary or next of kin would not respond to the form request, then the medical records along with the TPL waiver should be submitted. So in order to prove this, Cloudmed has a waiver that we have been using pretty successfully for several years now. And basically it just restates that TRICARE manual language that the provider has attempted to recover the form to no avail. We have had a lot of interest in this in the past, so our contact info will be up at the end. If anyone would like a copy of that waiver, we can walk you through it. We can send it your way if this is a risk area that hits home for you at your facility. So tying back to a dollar loss here, we're talking all about lost revenue. So the revenue impact is going to vary based on the TRICARE allowable, but in this specific example, it is $20,000 per claim. So we all know how hard it is to track down a patient once they leave the hospital. And we know that you encounter some patient non-responsiveness pretty consistently. So my goal here is just, I'm hoping that this is a relatively straightforward, simple area of opportunity to scan across your zero pay TRICARE volume. And hopefully it's pretty easy for you guys to collect. So that wraps it up as far as our actual case studies go. But while we were updating you on some ways to find that lost revenue within your system revenue cycle, we thought we should also share some newer information about another traditionally tough payer, and that is federal workers' comp. So although the update that we're going to give is from last year, we're still finding that some of our clients still think that this update is relevant. So that's why we wanted to share it with you guys today. So as you can see here on the slide, back in October of 2020, the Department of Labor's Office of Workers' Compensation Programs officially changed their medical bill review vendor from Conduent to CNSI. So as you might expect, especially in today's environment, we are finding that the transition is a little choppier than expected. And in fact, many providers that we work with were not necessarily even aware of the claim processing changes because the notification letters weren't sent to the appropriate places. So even though this is from April of last year, we figured it would still be relevant in case there's anyone who is unaware of this change. So CNSI is now responsible for all bill review, authorization, and payment matters. And I did want to put just the most important updates that impact your federal workers' comp volume up on the slide. So even if you know about the change, it's probably still a good refresher to know about these forms that need to be submitted if there's ever any sort of dispute that you want to have with federal workers' comp. So the first is the new adjustment forms. These need to be sent in every single time there's a denial, there's an incorrect denial, there's any sort of payment dispute. You need to be sending in these new adjustment forms. Second, there are also new authorization request forms for federal employees and for Department of Energy employees. And lastly, if you have previously had access to the Department of Labor's web portal, you should have received letters that provide access to the CNSI web portal. I am hopeful this new portal, it will allow you to check bill status, submit claims, and request authorization amongst many other services. So CNSI is making a strong push for electronic bill submission alongside this transition. And finally here, I wanted to just share with everyone a screen grab. Here's a sample of that new bill adjustment request that needs to be submitted every single time you have a payment or a denial dispute. I know that federal workers' comp is traditionally a very complicated payer class. So of course, getting that correct payment becomes even more difficult when the claims processing regulations completely shift. Recently, we are seeing that these new requirements tend to be causing a huge influx of denials for our clients. So to the extent that your patient accounting system maps federal workers' comp to its own insurance plan code, my recommendation would be to sweep that volume for any denials or zero pays that might have been a result of this claims intake process that happened earlier last year. Okay, so I have talked everyone's ears off. I believe Erica and I have spent the last 50 minutes or so giving you guys some tangible takeaways to recover lost revenue within your healthcare system. If this resonated with you, I want to thank you for spending the time with us. We are both very obviously passionate about finding lost revenue. So with that, I think we're at a close. I'm going to put up our contact info and ask Lori to kind of moderate. I don't know if there are any questions.
Yeah, we do have a couple, and of course, lots of people requesting the TPL form, the TRICARE waiver form.
Yeah.
So, which I'm sure you both expected to have some of that. So again, just reminding everyone, if you have a question, go ahead and use the Q&A box, and we'll get those questions over to Katie and Erica. Here's one for you guys. How do I know if my claim qualifies for the new tech payment?
Ooh, I'm happy to take that one. So this is a very timely question. The fastest way to determine if a single claim qualifies for the add-on payment is to use the CMS PC pricer. And you see that the fiscal year began October 1st of 2020, but CMS has not released the pricer yet. But as of last night at 5:15 p.m., they released their brand new web PC pricer. So I was pretty excited when I saw that update this morning. So you can key the claim information into that web PC pricer and make sure you add the new tech procedure code where it gives you the option for a procedure code. So you don't have to add every procedure code on the claim, just the one that qualifies, and it'll spit you out the pricing amount, and it'll let you know how much of that total payment is associated with the new tech product. So it's pretty fancy form, and I am very excited that they finally released the pricer 4 months after the fiscal year 21 releases were made.
Okay. All right, next question. If we don't have documentation of a positive COVID test, can I still get the new COVID treatment add-on payment?
Ooh, unfortunately, no. The only way that new COVID add-on treatment is billable is if you have the diag and have that positive test in the medical records. And so that if you don't have a positive test, you would write in the remarks, no pause test, just like you would on any other COVID case that you're essentially self-auditing and stating that you know that you don't have the documentation on file, and they will not apply the add-on payment for those cases, unfortunately.
Okay. And then again, just as a reminder for the presentation and the recording of this presentation, you see Erica and Katie's contact information here. They're going to be making the material available directly. So if you will contact them to request a copy, they will help coordinate that for you. The other question that I saw just come in again is on continuing education credit. So just to reiterate, this is the third of 3 sessions we've been doing as part of HFMA Region 5. Today, this session is sponsored by the Georgia chapter. So our process for issuing continuing education credit is that we will send, I will send you a form on Friday with other information, and you can use that continuing education form to self-submit on the on the national HFMA website. Okay, just asking one more. Any other questions? Okay. Well, Erica, Katie, lots of great detail here. So thank you very much for sharing the information, and thanks to everybody else for participating in the webinar today. So this is the last of our sessions for HFMA Region 5. As I was mentioning earlier, we do this as part of a region quarterly. So the next time we'll do an HFMA Region 5 day will probably be in the March-April timeframe. And for the Georgia HFMA, we will resume the bi-weekly Wednesday webinar series later this month. Please be on the lookout for registration information for the webinar, The Best Defense is a Good Offense, and we'll be hosting that on January 27th. I know the Tennessee and Alabama chapters, I believe they host webinars regularly on Tuesdays. And again, just check the events calendar on your respective chapter site for all the details. Katie, Erica, thanks so much again for sharing your expertise with us, and everyone else, have a good rest of the day. This wraps up our session.